Group 1 and 2, and we're going to present on 2 cases today. So our first case is partial caudectomy in a German Shepherd dog. So this is Lucky, a 3-year-old male German Shepherd weighing 29.2 kg with body condition 2 out of 5. He is a working dog under PDRM, and the vaccination and deworming status were up to date. For history, on 26 October this year, he had non-healing open wound at the caudal tail, exposing the coccygeal bone, and there was also serious discharge due to hyperactivity in the cage. The treatment was given, and he was scheduled for a surgery. The radiology on the coccygeal bone and biopsy were also done on the same day. On 15 of November, he was admitted to UBH, and the partial caudectomy procedure was done the next day. Upon physical examination, the temperature and heart rate are within normal range, and he was panty, bright, alert, and responsive with pink mucous membrane, CRT, and skin tan less than 2. He had clear lung sounds with good temperament, and there are 2 holes of non-healing wound observed at the caudal tail, exposing the coccygeal bone at one side. There was also green pus discharge at the open wound. So this is the physical examination of the tail with the coccygeal bone exposed. There was also localized swelling surrounding the non-healing open wound. So for our problem list, problem number 1, the non-healing open wound at the caudal tail with our top differential traumatic injury as due to the history of getting the wound in the cage while being so hyperactive, and then mysis, and our third differential diagnosis, neoplasia osteosarcoma. For the green pus discharge, our differential diagnosis may be due to secondary infection due to problem number 1. So we plan to do CBC and serum biochemistry, radiology, biopsy, and bacterial culture.
For our CBC, there is no significant findings. But however, for SBC, there is slight hypoproteinemia and also hypoglobulinemia. For the radiology, DV view, there is presence of decreased radial opacity of the last 3 coccygeal bone, and our radiological diagnosis is osteolysis. Next is the increased radial opacity of the soft tissue surrounding the coccygeal bone as indicated by the blue arrow, and our radiological diagnosis is inflammation. For the right lateral view of the tail, there is also similar findings as the DV view, which is osteolysis and also inflammation. For our biopsy result, the sample shows severe inflammation characterized by mixture of viable, degenerated, and necrotic inflammatory cells infiltrate. The capillaries are congested and thickened, and there is no evidence of neoplasia. So for our updated problem list, we rule out myositis and neoplasia, and our differential for the non-healing wound is osteomyelitis post-traumatic injury. However, we couldn't rule out the secondary infection due to pyogenic bacteria as we didn't do any bacterial culture. So Lucky entered surgery on the 16th November for partial caudectomy.
Beginning with that, Lucky could be controlled. And proper when bolus going back for IV, it was given by a block. Hello, can I be heard clearly? Okay.
Yeah, now better. Continue.
Okay. Induction for induction 0.1 ml per kg IV was given by blocks, and 13 blocks were given by isoflurane 1.5%, and it was topped up with propofol at 0.1 ml per kg, and 2 blocks were given. Additionally, for for multimodal anesthesia, local anesthesia was given in the caudal epidural. Bupivacaine was for the duration, for the longer duration, for about 4 to 6 hours, and morphine was also given as an analgesic in the epidural space, which would last about 12 to 24 hours. Intraoperatively, the analgesia that was used was ketamine CRI at 0.12 mg per kg per hour. And when we stopped the CRI, which lasted for about an hour, we used meloxicam at 0.1 mg per kg subcat. The caudal epidural was done, and here's the video that you all can see how it's done. So once the needle is in the epidural space, use drop method, and if negative pressure inside, the droplet will seep into the spine. So, the beauty. Okay.
Next is the surgical protocol for partial caudectomy. First, the patient is placed in a sternal position. Next. The patient is placed in a sternal position. Then next, the distal part of the tail is wrapped with a sterile thread and secured with WOW gauze. Next. Then the intervertebral joint to be transected is identified, and a double V-shaped incision is made from dorsal to lateral, then ventral aspect of the tail of about 5 cm cranial to the affected tail. The double V incision are to create dorsal and ventral skin flaps. They are sufficient to cover the exposed vertebra. Next. The soft tissue slightly distal to the desired intervertebral space is incised. Next. Then the medial and lateral caudal arteries and veins are ligated with 30 PDS. Next. The distal tail is disarticulated with a scalpel plate, and a circumferential ligation is placed around the distal end of the remaining tail when bleeding occurs. Next. Lastly, the soft tissue are opposed with a continuous horizontal matrix suture pattern of size 30 absorbable PDS, while the skin flaps are opposed with simple interrupted suture pattern of size 40 non-absorbable epithelium.
So for the post-operative management of Lucky, 2 broad-spectrum antibiotics were given to prevent bacterial infection, which were amoxicillin clavinate at 17 mg per kg and clindamycin at 11 mg per kg. This was given for the days day 1 to 4 as well as day 1 to 3. The other medication given was anti-inflammatory agents to relieve post-op pain and inflammation, such as tapase per os, 1 tablet, as well as meloxicam at the dosage 0.1 mg per kg. This was given also on the same dates, day 1 to day 4 post-op. Wound dressing and bandaging was also done once a day to check the suture site and to also make sure that no contamination and bleeding is controlled. And on the first day after the surgery, lactated ringer solution was given at the maintenance rate 40 ml per kg per day intravenously to prevent dehydration. And Lucky is always kept on an e-collar for him to stop licking the suture site. Next. So from the image over here, we can see that there is little seroma and minor bleeding observed, and all the sutures are intact. Next. So for Lucky, we would say that the prognosis is quite good, as there was only minor seroma fluid and bleeding, which was noticed, and he is tentative to be discharged from UVH on 19/11, which is today. The most important part, which we like to educate the clients about, is that the wound must be dressed and bandaged until the suture site is completely healed, and the movement of the bandage area should be restricted to prevent the suture breakdown, and that the dog should always be kept on an e-collar, since this dog is known to be a hyperactive one. That's all about Lucky.
All right. Hello. Good morning, everyone. I have a very basic question. I would like to know whether you can actually explain to me the principle behind providing lactated ringers and how does it work? What's the component in there?
The main principle of giving lactated ringers is to restore the electrolyte imbalances and the fluid loss during surgery. The common electrolytes which are found in lactated ringer solution are calcium chloride, potassium chloride, and sodium chloride, as well as lots of water.
Dr. Ben here. Look at your anesthetic protocol. The protocol have to put mg per kg. Don't put 10.1 mg per kilo. Because not everybody is working in hospital here. So they don't know the concentration is 10 mg per ml. So nobody will know your dosage. So you write 1 mg per kg. And then the induction dose is wrong. That's why I ask you don't prepare your slide on Thursday. You Tuesday, Wednesday, so many times you don't want to prepare a presentation slide. The propofol I use about like, remember it's about 4 mg per kg was written at the anesthetic form. So induction is 4 mg per kg. Then 13 blocks is what? 13 blocks is, 1 block is what? So audience will not understand because they don't work in hospital. Understand? So all those things is not good. Okay. Then the maintenance also not good. Maintenance is isoflurane 1.5%. The propofol is sometimes, let's say you feel it's light, instead of increase isoflurane, suddenly you use like 1 mg per kg top up, something like that. Okay. So, and then meloxicam dosage also wrong, because this is a first day. So loading dose is 0.2 mg per kg subcut. That's why don't do work last minute. Although you guys don't sleep for 1 day and do presentation slide, you can clearly see this is last minute work. Okay, and then the video for the epidural also wrong. From that video, nothing can be seen. You want to show people hanging drop method, right? Then the fluid saline was aspirated, right? Not this video. You took a few video before that. Yeah, so this video actually nothing to be seen. It's just injected and then you see the bubble inside, the gas bubble in this syringe was not compressed, that's all. But there's nothing to be seen here. This is not a hanging drop method. So video also wrong. So meaning that you don't understand. So next time prepare earlier. Then you've got time to ask also. Oh, this surgery was performed on Tuesday. Then don't do last minute work. Okay, thank you.
Understood, doctor. Thank you.
Hi, students. Can you hear me?
Yes, doctor.
So what is the purpose of the cocktail of bupivacaine and morphine in epidural?
The cocktail of bupivacaine and morphine is in a way a multimodal analgesia. The bupivacaine is to prevent the transmission of pain upwards through the spine, and the morphine is to last act of ventilation aspect of pain. And also because in the spine will last a longer time for about 12 to 24 hours as an analgesic. Does that answer the question, doctor?
Actually, I can't hear you.
Oh, I'm sorry. The bupivacaine and morphine cocktail works as a multimodal analgesia, and the bupivacaine acts by
Change speaker lah, Malik. We can't hear you actually from just now until now.
my speaker.
Ask other people answer. Thank you.
Okay.
Doctor, Malik was trying to say bupivacaine and morphine into caudal epidural, so that bupivacaine has a anesthetic, like 4 to 6 hours has an anesthetic, and also morphine, it can last up to 24 hours as an analgesic. This done to prevent transmission from the nerve, and has post-op pain management also, because morphine is still in the caudal epidural.
Is it better if you want to answer in terms of where is the site of action for each of these drugs?
Hello, can I be heard? Can I be heard clearly?
Yep.
Okay. For the local anesthesia in the epidural space, you'll be trying to block the nerve transmission at the sacrococcygeal joint. And so you're hoping the pain doesn't move upwards. And for the morphine, it's working centrally in the brain.
Again, wrong. Number one, I'm not injecting at the sacrococcygeal, so this is not caudal epidural. I'm injecting at the lumbosacral. Okay. So then number two, your opioids, morphine now is not targeting at the brain. You're injecting at the epidural, which is very near to the when you see the cross section of the spinal cord. So you will see it looks like a butterfly. So the nerve will branch out. So the dorsal horn of the spinal cord is where the opioid receptor will sit at. So if you see your dosage is 0.1 mg per kg, right? So if let's say normally if you injected intramuscularly, which is systematically, you will require higher dosage, because now you are injecting into intramuscular, then it go to the bloodstream, then it go to the whole body, then only reach your receptor at the dorsal horn of spinal cord. So that's why you need higher dosage. But then if you are directly injecting into the epidural space, now your drug is near to the where is the receptor located. So it will be more specific and you require lower dosage. So this is how you answer these questions. And why we mix these two is because we want to the duration of the analgesic to prolong. So as you can see, this dog, the analgesic effect after that, even it can last for 1 day. So that's why you didn't see me for post I keep giving tramadol or morphine or whatever, because we have done a good analgesic management during the surgery, which can last after the surgery.
Okay, thank you, doctor.
Okay, student, why ketamine was given as pre-med in this case?
You answer. Yes or no? Don't keep silent. Silent
They
is
are
what?
Googling, Dr. Ben. That's
Oh.
what they're good at.
Okay, so I give you a hint. We are giving ketamine CRI, right? So before we are starting CRI, what should we give? Before we starting one CRI, normally what should we give? This is what you should
For the
Google.
loading dose first.
Correct. Who are you? Very smart. Good, good. Who are you? Malik. Yeah, so we need a load. So we need a loading dose, but normally we no need so high for the loading dose until 2 mg per kg. Normally, what is the loading dose for CRI? You Google this one. What is the loading dose for CRI for ketamine? Now this is what you Google. You Google also must know how to key in.
Is it 0.6 mg per kg?
Okay, so it's about like 0.25 to 0.5 mg per kg for the loading dose for ketamine CRI. Okay, so but not why I give 2 mg per kg. Remember what is this top body weight?
29.2 kg.
Okay, so 29 kilo. So if I say I need about normally this dog will take about, if let's say without pre-medication, it will take about like 7 to 8 mg per kg. Okay, let's say 10 mg per kg, then the concentration of propofol is 10 mg per ml. This dog is 29 kilogram. So how much volume of propofol should I need? Let's say 10 mg per kg lah, then 10 mg per ml, then 29 kilo. So how many milliliter of propofol should we give? Wait,
29.
oh, correct lor, 29 ml only ma. Then in one bottle of propofol, how much do it contain? Does it contain? Don't know, never mind, I tell you 20 ml lor. Oh, so that means if I want to save my propofol, I don't want to open so much propofol. So what can I do? Can,
Use ketamine.
Yeah, so there's something, a technique called catapult. So meaning that during induction, I can combine ketamine and propofol together. So the only purpose is to save the propofol. And then besides that, besides saving the propofol, actually this combination, when they do research, they see the blood pressure and also the recovery time. Blood pressure will be more stable compared to using high dose of propofol alone, but then the recovery time will be almost the same. So this one called Catapult. So you want to Google, then you Google Catapult. Understand? But eventually, my purpose is I don't want to open so many bottles of propofol just for induction. Understand?
Yes, doctor.
Okay.
Okay, student, since this is regarding the ketamine loading dose and CRI, may I know what was the time difference from the pre-medication at 2 mg per kg of ketamine and intraoperative analgesia CRI?
The pre-medication was given at 9:30, and we went at 10:05.
Malik, I can't hear you.
Sorry. The pre-medication was given, I think, 9:30, and we went into the operating theater at 10:05.
10:05.
Yeah.
Okay.
Then you answer one question. During the before the intra-op, during prepping, did we start ketamine? CRI? Yeah, so the CRI already started during the prepping area. So meaning that after we give ketamine, then during prepping, we already start CRI.
Alright guys, coming back to my very basic question just now, it sounded very lazy of you to answer about Ringer's lactate solution by saying that it contains minerals. I mean, my concern is that could you please explain the principle behind having lactate over there? Why is it important for the maintenance of the animals after the operation?
Actually, so for lactate itself, lactated Ringer solution is a balanced electrolyte. So basically, the lactate itself being present in lactated ringers is that the function of it is to be able to be metabolized by the liver in order to produce HCO3 or carbonate ions. So when this happens, it actually prevents metabolic acidosis or reduce the effect of metabolic acidosis. So in aside from correcting the fluid deficit and to provide maintenance fluid rate for the animal itself, it also prevents metabolic acidosis to occur.
Excellent, thank you.
Are there any more questions for this case?
Okay, next presentation.
So moving on to the next presentation, our case will be the lumpectomy of a left ventral abdominal epithelial tumor in the Mongrel beach. Next. So for the patient segment, this dog is Pony. It's a 12 years old spayed female mongrel that weighs around 23.2 kilogram. It has a body condition score of 4 out of 5 and is managed using a multiple dog household. So vaccination status of Pony is up to date. However, the deworming status is not up to date. On November 2019, Pony was tested heartworm positive for heartworm antigen, and it was given treatment for the course of year 2019 to 2020, and it was on heartworm medication ever since then. Next. So for the history of Pony, the owner actually notices the mass on the 17th of June 2019. The ventral abdominal mass was noticed with a mixed consistency. Ultrasound was done to rule out abdominal hernia, and the mass was diagnosed to be more likely from a cutaneous origin itself. So last year on October 15, Pony was brought into UVH for the mass, and the mass itself has grown to an approximate size of 10 cm times 7 cm. Med check was done by then, and finally on the 11th of November 2021, Pony was admitted for surgery in UVH. The surgery was scheduled on the 17th of November. Next. So for the physical examination of Pony, temperature is within the normal range as well as the heartbeat. The respiration rate was not taken as Pony was panting. Other than that, Pony was quiet, alert, and responsive, have a pink mucous membrane, have a capillary refill time and skin time of less than 2 seconds with clear lung sound, and the presence of a fluid film max that weighs measures approximately 10 to 10 cm of the left ventral abdominal region. Next. So based on this, our problem list will be the mass at the left ventral abdomen itself. The top differential diagnoses are lipoma or liposarcoma, mammary gland neoplasia, which includes mammary adenoma, mammary carcinoma, and mammary gland adenocarcinoma, as well as mast cell tumor itself. For the diagnostic plan, CBC and serum biochemistry was done, as well as for FNA cytology, biopsy, and radiology itself. Next. So radiograph and ultrasonography was done on the 16th of November. Next. On the VD view itself, you can see the chest radiograph is having clear lung fields and there's no evidence of metastasis. Next. On the lateral view itself, similarly, there is clear lung fields which indicates there's no evidence of metastasis. However, there is a few bronchial pattern near the hilar region which may indicate bronchitis in this case. Next. As for the ultrasonography of the mass itself, you can see here that the mass is having a mixed echogenicity, which is both hypo and hyperechoic in this case. Next. So FNA was done as well on the 16th of November, and the result came back, next slide please. And the result came back that it could possibly point towards squamous cell carcinoma or squamous cell hyperplasia. In this case, the squamous cell can be seen with multinucleation as well as prominent nuclei itself. Next slide. So for the updated problem list, squamous cell carcinoma and squamous cell hyperplasia was added in. For a diagnostic plan to obtain a definite answer, excisional biopsy should be done and the sample should be sent for histopathology. Next slide.
As for the anesthetic protocol, it is Pony is rated as a ASA class 3. Pre-medication was with ketamine 2 mg per kilo and propofol 5 mg per kilo, both at IV. And induction is mostly using propofol as well. Maintenance is using isoflurane 1.5 to 2.5%. Most of the time it was maintained at 1.5%, as well as using propofol to maintain as well. As for intra-op, petidine, ketamine, and meloxicam is used. Ketamine was for CRI 0.12 mg per kg per hour between the time of 9:30 to 11 a.m. and 0.6 mg per kg per hour between the time of 11 a.m. to 12 p.m. And meloxicam was given after ketamine CRI has stopped. And then local anesthesia using bupivacaine is also used. I would like to correct also, there's some mistake here. Actually, propofol for pre-med is at 1 mg per kg. Yeah.
On to the surgical protocol. So first, Pony was placed with dorsal recumbent, and a marginal incision was done with electrocautery method. The electrocautery used in this surgery has end with monopolar spatula electrode. As seen in the right picture, it was set in dry cut mode, 35 watts. The location of the masses can be observed in the middle picture. The bigger mass had a size of 10 cm and located at the left ventral abdomen. The smaller mass was sitting powder and mass and size is roughly about 1.5 cm. Then the incision was continued the factor of external reflection. Incising both and subcutaneous blood vessel was cauterized with bipolar cautery forceps. The bipolar forceps used in this surgery ends with a 4 electrode, as seen in the right picture. They were set at bipolar force coagulation mode 30 watts. So two switches were done on the mass, then a size surgical bed was used to record the switches for fluid suction. About 300 ml of it was collected from the mass. dissection, a blunt dissection was performed for tumor excision by dissecting the subcutaneous and after excising the tumor, it was sent to lab biopsy. Tumor growth area was then lavaged with sterile saline water to clear off possible tumor cell. Hiding flame foam flap was harvested to close the large layer was approached with modified machine cup by using size OPDS with a half round body. While closing the subcutaneous layer, a panel strand was placed along the lens suture side as shown in the right picture. The strand was anchored at the point with a track pattern by using size 3011 as shown in the left. Closure was done with grafted shape pattern by using size 011 with a 3/8 circle reverse cut. After that, stands were placed at the switch line near the left. Stands were fixed with horizontal metal suture pattern by using size 011.
For the excisional biopsy, the mass sample was sent for the histopathology and the result is still pending. Next slide. For the post-op complication, Pony is prone to hypothermia after the surgery, so the body temperature fell to as low as 35 degrees Celsius during the surgery, and Pony is placed in ICU under the warm blanket with 47 degrees Celsius to stabilize the body temperature after the surgery. And the temperature rose from 35 degrees Celsius to 38.3 degrees Celsius in 1 hour afterwards. Next slide. So for the post-operative day 1 on 18 November 2021 at 9 a.m. was dry and still intact. Next slide.
Okay, so for the post-operative management, day 1 post-lumpectomy, Pony was given 2 types of antibiotics, which is amoxicillin and enrofloxacin for 3 days. This is to prevent bacterial infection, and also meloxicam at 0.1 mg per kg for 3 days for post-op pain management and to control any inflammation going on. Tramadol at 5 mg per kg was also given twice a day for 2 days as an analgesic for post-op pain management. Papace twice a day for 3 days as an anti-inflammatory to bring down any swelling. And chloramine was also given at 0.5 mg per kg subcut. This is because we still haven't got a real diagnosis, so mast cell tumor is still in the DDX, and this is an antihistamine to control the effect of mast cell tumors such as gastritis. Next slide. IV fluids at maintenance rate to prevent dehydration, and also cold compression was done once a day for 2 days post-surgery. This is to reduce any swelling by vasoconstriction and to also relieve any discomfort on Pony. And drainage management of the IV extension line that was secured down the suture site. This is to prevent any seroma accumulation in the dead space after surgery. And body bandage and wound dressing once a day to prevent any suture site contamination and also to decrease the dead space. And lastly, e-collar from day 1 till the wound heals to prevent any leaking of the suture site. Next. So the prognosis for PONY is guarded. This is due to the complications that we have in PONY, which is the liver. There is a continuous high ALP since PONY's previous visit, and he is on some liver supplements. And also due to the heartworm causing heart damage, we do not know how severe it is because there's no ultra echo done. Next. So for client education will be strict cage rest due to just fresh suture site and also the heart condition. And client should monitor the suture site daily, ensure it's clean and intact. E-cooler should always be put to prevent any biting, licking and scratching. And Pony is also quite obese, so maybe can reduce some body weight. And to continue the heartworm preventive has a conservative treatment of heartworm has opted by the owner since 2019 when Pony was diagnosed by heartworm. That's all from us. Thank you.
Hi, good morning. Could you please enlighten me about the mechanism on how PAPase works as an anti-inflammatory drug?
Papase contain papain, which is an enzyme, and it has anti-inflammatory properties.
And some more.
Papain is actually from the papaya tree, doctor.
I know it's from a papaya, but I want to know the mechanism how this PAPase works because you actually listed it there. So it would be nice if you can briefly explain the mechanism. Any of you?
Hello, doctor. Can I be heard clearly?
Yes, Malik, you can try.
Okay. It's a enzyme, so it kind of breaks down the proteins which promote inflammation. But from what I understand, it's separate from the COX-1 and COX-2. But I don't know if there's a lot of literature about papain itself. Papain.
Yeah, it does. So you're almost there. So that's good to know that someone here actually understood the basic mechanism. All right. So, whatever you listed there, the types of medication and drugs, you should know at least basic mechanism on how it works. All right. So please read up on this. You still have another year to go.
Okay, thank you, doctor.
Can you go to the anesthesia slide? So similar to the previous case, I assume that this ketamine pre-medication and then CRI is actually a loading dose. Then why, I mean, this is just my suggestion, would be better to write it as a ketamine CRI by the loading dose followed by a CRI. And why you are writing that in pre-medication? Number one. And number two, you mentioned propofol 5 mg per kg IV as a pre-medication and again as an induction propofol 5 mg per kg IV. Could you explain that?
The pre-med is there's a typo there actually. It's a mistake. It's actually 1 mg per kg.
Okay,
And yeah, yeah, noted that we will next time write it as a preloading for ketamine.
yeah, I assume that this is preloading, not pre-medication. Because when you write in pre-medication and then you write a CRI intraoperatively, that is confusing.
Everything was good until your prognosis. The prognosis is because the AP is high, you think got liver disease, and then because of heart disease, so you think you got heart condition. So the sequence is incorrect. The sequence is before you perform anesthesia, what is the anesthetic risk? Then maybe you can put one slide. Okay, this dog is obese. BCS is 4 out of 5. So the FRC could be less. Then you may have difficulty for the ventilation under general anesthesia. So what we need to do like that. So risk and then what we need to do. And then he got heart disease. However, the like symptoms of the heart disease like coughing, like exercise intolerance was not reported. And then the echo was also not done. And then the heartworm treatment also not performed here, was performed at private hospital. So the status is also unknown. Okay, so that will also add a risk, something like that. You understand? So not at the last, until the end, your prognosis is guarded. If prognosis until the end here, after the surgery, what we may worry is because the surgery, he removed the mass and then now he's doing flapping. So now we worry that later on, when the dog move too excessively, then there is a chance for the suture breakdown. Or if let's say the environment was not good, it's not clean, then there is chance for secondary bacterial infection. You get what I mean? So the sequence
Yes,
of your
doctor.
presentation is important. After you finish the surgery, the heart and the liver is not your concern about this dog. What is more top of your concern is whether the suture breakdown will occur, whether there will be a bacterial infection, like that. Understand?
Okay, doctor.
But before that, everything is okay lah, very good lah. Okay.
Thank you.
I would like to ask about the surgical protocol. I think I heard the presenter saying hand roll straight. Am I right? Hello.
Yes, doctor.
Sorry, can you speak louder?
Yes, doctor.
So, is that really a hand roll straight?
Hi, the slide with the dog on dorsal recumbency, a drawing slide with the one red line.
At close suction.
So this is not a hand roll straight. This is an IV extension tube, and we modify it to become an active drainage. So please Google to look for how pen straight look like and if pen straight can be used for active drainage or not. Pen straight is not meant for active drainage, it's for passive drainage. This is active drainage. So normally we either use butterfly catheter to modify or this IV extension line. For a better one, normally there's one kind of drainage called Jackson Pratt, but we don't have that, so we have to modify using what we have. And another thing is that your treatment protocol. I think many of us have already mentioned that do not write the duration of treatment up to the day you present it, like for 3 days. We want the total of day that we plan to put the animal on antibiotics. How many days we plan to put the animal on meloxicam, not until day 3. and that's all. So after day 3, there's no medication, is it? So I wish you take note of this, and I hope the next groups they do not make this same mistake again. And I have already informed your DVM4 junior why is this dog on 2 types of antibiotic. Did you share with your friend? These are the important information that you should share with your friend instead of waiting for people to ask you, or I don't know why you want to keep the information to yourself. Is it normal to put 2 types of antibiotic for an animal right after surgery, any kind of surgery?
No, doctor, usually one is enough.
So why in this case? You didn't ask your DVM4. You asked your DVM4 to ask me what's my answer, and I already answered your junior.
Because doctor, for Moxilla itself is not strong enough to prevent the infection due to the fact that the surgery is having undergone a long hour surgery, and as well as there's a large surface area being exposed. So in that instance, enrofloxacin was added in. But initially, before Moxilla was given, Augmentin was attempted to be given. However, due to the fact that the owner said the dog may snap, Augmentin was not given orally, so it was changed to amoxicillin or Moxilla.
Yes, because this dog is fractious, we want to give injectable antibiotics, but because we do not have amoxiclavulanic acid injectable, the dog was given amoxicillin injection instead. And that's why, thinking that we cannot give oral medication and we need injectable, so that's why we gave enrofloxacin. And amoxicillin was not stopped immediately right after we changed to enrofloxacin. It was maintained for at least 3 days before we stopped it. Thank you.
Hi, student. What is the effect of mast cell tumor in your chloramine?
Dr. Chloramine has antihistamine so that it will prevent and mast cell tumor side effects such as gastritis, and because mast cell tumor has granules of histamine that can be released.
Doctor, for the mast cell tumor effects itself, it is meant that in the event if it is a mast cell tumor and manipulation of the tumor itself causes degranulation of histamine granule, it may lead to things like, in severe cases, anaphylaxis, as well as edema or bleeding. So for chloramine itself is to prevent and counter the effect of the degranulation of histamine.